All righty, folks. Well, we'll go ahead and get started. Thanks for everybody who is joining us here. We're going to record this event as well. So, for those who are playing it back later, thanks for taking a listen. I'm David Moore, one of the urologists at Deaconess Clinic. And we're going to talk a lot about men's health today because it's a very important topic. Let's see here. So, I do have a website. You can pull it up now or pull it up later that has a lot more information on most of the topics that we'll cover tonight. So just a bit about me. I'm born and raised here from Evansville, so I'm a longtime member of the community, got friends and family here. I like to tell folks, I'm not going anywhere. I'm here for good. I went to DePaul University for my undergraduate degree and then spent about 10 years down in Nashville. Went to medical school there and then did a 5-year urology training program. It was a great experience. Vanderbilt's one of the top urology training programs in the country, probably one of the top 10. But was happy to make it back home to Deaconess in 2018. So I'm starting my 7th year of practice now. I have no relevant disclosures. That just means I'm not being paid for any of the things I'm saying. I'm not a consultant for any device company or selling any of these medications or anything like that. So tonight's agenda, we're going to talk about, men's health. What problems do we all experience as we get older? Certainly, we're going to talk about the prostate. What is it? What sorts of problems do you experience with the prostate? Then what are the treatments? And then we'll talk about erectile dysfunction as well. And everyone will have an opportunity to ask questions via the chat icon down below. We'll be monitoring that. So even if you have questions now, you can go ahead and type them in and we'll address them towards the end of the webinar. So, what problems are we going to experience as we age? We all want to know what the future holds, what sorts of things can hurt us. First things, of course, we need to talk about our snakes and spiders. This is a copperhead. This is a brown recluse, terrifying creatures. Okay, maybe not all that common, but at least to me, these are the things. I'm just joking. We're going to move on to the more common things that will actually hurt men as we get older. Cardiovascular disease. Absolutely. Cardiovascular disease is the leading cause of death for men in America. So major risk factors, most people know all these. Smoking is the big one. We're going to touch on that later on because smoking is also one of the major risk factors for the most common urologic cancers, bladder cancer, kidney cancer, smoking, biggest risk factor for those. High blood pressure, 50% of men have high blood pressure, and that's a major risk factor for cardiovascular disease. Diabetes, obesity, diet, exercise, and high alcohol intake. All of those are big risk factors for cardiovascular disease. So what can we do to help with that? Well, obviously we talked about smoking. Quit smoking. Don't start if you haven't. Talk to your PCP, your primary care doctor, about getting your blood pressure checked. You might need medications for that. Get tested for diabetes. And if you have diabetes, keep your blood pressure under good control. Keep that A1C down. You want to check your lipids, your cholesterol and triglyceride levels with your primary care doctor. And healthy food, regular diet, or regular exercise, 30 minutes, 3 times a week. Keep your alcohol intake to a moderate or low level. And as always, we all want to lower our stress levels. Stress hormones are going to ramp up that cardiovascular system and increase your risk of cardiovascular disease. Mental health, something else I wanted to touch on. Mental health disorders, incredibly common. Just want everyone to know about that, something that not all men want to talk about, but you're not alone. More than 1 in 5 U.S. adults have a mental illness, and men in particular are less likely to receive treatment or seek treatment for mental health disorders. And that has a major effect. Depression and depression leading to suicide is a major cause of death in men. It's in fact the 7th most common cause of death in men. And men die at a rate almost 4 times as high as women from suicide, and they account for almost 80% of all suicide deaths. So this is not uniquely a problem of men, but certainly something that's undertreated, underdiagnosed, and many folks aren't as aware of it. So these are some of the signs, you know most of these, but putting them out there just for reference later on. If you're having any of these thoughts, anxieties, or issues with your behavior or your mood, certainly your primary care doctor can be a great place to start. They're an excellent resource, very accustomed to handling mental health disorders in at least directing you in the right direction if we need to get you set up with a mental health professional. So now we're going to move on to the main event, which is men's urologic health. We're going to start with the prostate. And so what is the prostate? That's that gland, sits down there in your pelvis, about the size of a walnut. It surrounds the urethra and makes most of the parts of semen or ejaculate. That's its job. But what sorts of problems does it cause? Well, you may have heard of prostatitis. That's inflammation or infection of the prostate. That causes these sudden symptoms of burning, stinging, pain, pelvic discomfort, difficulty going to the bathroom. Prostate cancer, typically no symptoms with that. We're going to talk about it, but that's the most common cancer in all of men. So very, very common. And then that enlarged prostate or BPH, that causes these gradual symptoms over time. And they cause different problems in different men, and you can have more than one of them, and having one of them doesn't necessarily mean you'll get the other one or anything. So first, to talk about prostate cancer, just urologic cancers in general, you can see prostate up there, #1 cause of cancer in men, and the second leading cause of cancer death in men, second only to lung cancer. We also have bladder and kidney cancer up there, accounting for almost 40% of all cancer diagnoses in men. So of any of the men out there suffering from cancer, many of those are going to be urologic cancers. So that's about 70% of my practice is oncology or cancer treatment and surgery, just because it's so incredibly common. But what can you do about it? What can we do about prostate cancer? Well, good thing there's a screening test. So there's a simple blood test. There's a lot of controversy about it, which I won't get into because that controversy has relatively been laid to rest with modern updates in screening guidelines. What we do know is 1 in 7 men will get prostate cancer. It's most common. And prostate cancer screening, PSA screening with a blood test, is going to reduce your risk of metastasis by about 30 to 40%. It's going to reduce your risk of death from prostate cancer among all of the entire population by 15 to 30%. So we should screen pretty much all men, age 55 to 70, upwards to 75 for most men, unless you have a lot of other medical problems. And then at-risk men, that's going to be men with a family history, a brother or father, grandfather with prostate cancer, or African-American men, because we know Black men have a much higher risk of prostate cancer. We're going to screen those folks earlier, starting around age 45, sometimes even earlier. One of the other things, we don't want to treat PSAs with antibiotics. So if you get your PSA, it's high, and you don't have symptoms of prostatitis or infection, antibiotics are just delaying potential, necessary care there. So kind of a summary here, we want to target age 55 to 75, sometimes younger if you've got any of those risk factors. It's a once-a-year blood test, simple blood test. Get with all of your other routine blood work and see me or another urologist if you have any PSA value that's above 3, but we always want to confirm that with a second measurement just to make sure it wasn't an error or some fluke measurement. So what else does the prostate do? Well, it grows. It starts out at a normal size through puberty. It starts to grow a bit more. Then it's a relatively stable size for a while. And then as you get to be about the age of 50, 55, it starts to grow again and encroach on the urethra. So that's BPH, benign, non-cancerous growth of the prostate. And that's the clinical term for the enlarged prostate, that problem that old men get when you're having trouble going to the bathroom. It's not just something that you have to live with and that is a part of aging. There are plenty of things we could do about that, which we're going to talk about. So we always want to rule out cancer. That's the non-cancerous growth. So anytime you see us, we're going to be talking about the PSA and prostate cancer screening. How common? Well, it affects about 40 million American men. So incredibly common. It's more common the older you get. So by the time you're in your 90s, if we're lucky enough to make it to our 90s, about 90% of men are going to suffer from BPH. So what are those symptoms? You kind of know most of those, but that urgency and frequency of urination, getting up multiple times at night to go to the bathroom, feeling like you have to strain or push the urine out, that weak stream, hesitancy, meaning you can't get started. It's difficulty to start and even stop the urination sometimes, and just stop it and start in general. Well, do I have to do anything about it? It's not overly bothersome to me. Well, if you have a large prostate that's blocking the bladder, I kind of compare it to having a heart, that's blocked by a valve. You've got an aortic valve that's blocking your heart, you can develop heart failure. Similarly, if you've got a prostate that's blocking the bladder, you can develop bladder failure. And so that's where we end up with men in their 70s, 80s, 90s who have catheters and can no longer empty their bladder because their bladder's lost function, permanent bladder damage. So how do we diagnose it? Well, we're obviously going to take a history from you. We'll see you in the office. We'll do a physical exam. We'll usually get some basic testing, do a survey of your symptoms. We'll get at least a PSA test. Oftentimes, we're going to do a little bit more evaluation with a bladder scope, cystoscopy. Sometimes we'll do an ultrasound of your prostate to get a very specific size measurement. But what we really want to know at the end of the day is how much is it bothering you, because treatment for an enlarged prostate is going to be somewhat elective. There are some things that we're going to say, you got to do something about this. But if it's just a matter of bother, we want to know how bothersome. So what are the treatment options? There's many. We said 40 million American men, so of course there's going to be a lot of treatment options in this space of medical diseases. And for me, when I'm treating BPH, it's definitely not one size fits all. We've got to individualize it to the man, but also the prostate, the anatomy and the size of the prostate. So we start often, with medications. We don't have to start with medications. We used to think that, but nowadays we don't have to. But oftentimes we'll start with medication. That's Flomax. I'm sure you've heard of that. There are some other ones as well. Obviously, big advantage, no surgery. You might get relatively immediate relief, but it's a Band-Aid on a problem. It's a mechanical blockage usually, and this is not a mechanical solution for a mechanical blockage. And there's potential side effects, of course. The big ones for Flomax are going to be potentially some lightheadedness, because it can kind of transiently lower your blood pressure, and usually major ejaculatory changes, which can go away if you stop the medication. But that's something that can really bother folks. And over time, you may find that it doesn't work quite as well. One of the options that I use quite frequently is something called UroLift. Absolutely not for everyone, and it's not a miracle procedure by any means, but one of the reasons we like it is it can replace medications. It's a quick in and out same-day procedure and not many side effects. It's the only treatment for BPH, FDA approved, that isn't known to have sexual side effects. And it usually doesn't require a catheter after the surgery, usually pretty quick return to normal activities within a week or so. There are, of course, some small risks. It's a surgical procedure, bleeding, infection, things like that. And it's really not as effective by any means as the more invasive therapies in reducing your symptoms. So I'll tell men, this is probably going to get you modest improvement in your symptoms. We're not going to hit a home run. It's not going to be like you're 18 years old again. But for most men who choose the UroLift, it's good enough. It's all they ever wanted. They're not looking to hit the ball out of the park. They wanted something that was quick and effective, and that fits the bill for most men with the right anatomy. So how does it work? Let's watch a quick video here. So we've put a scope on the inside of your prostate, and it's going to deploy this little needle and a little kind of wall anchor, as I describe it. It cinches up the outside of the prostate and pushes the lobes of the prostate off to the side. So kind of think of it like curtains on a stage. We're pulling those curtains up and out of the way so the urine can get on through that urine channel there. Kind of some before and after pictures. We'll usually use between 4 and 6 implants to open up the prostate and really widen that urine channel there. Then, of course, we've got major surgery. So that's going to be, just for example, that rotor-rooter of the prostate procedure, TURP, transurethral resection of the prostate. That's a TURP. That's going to be the most common procedure that I do. It's kind of the gold standard. It's what we compare all other therapies to. Any new therapies that come on the market, we're always going to compare it back to the TURP procedure because it works. It's been around for a very, very long time. It is more invasive, but no cuts or anything on the outside. It's still all done through the urethra. It's actually removing prostate tissue, not just moving it out of the way. And it's known to have a very high success rate and a low retreatment rate, low chance that we have to do anything else over time. Major surgery, going to have some risk with that, right? So it's going to require hospitalization. You've got to have general anesthesia. You're going to have a catheter afterwards, and that's why we admit you to the hospital overnight. You're going to have that then for 4 or 5 days and a longer period of restriction. So slower return to your normal activities. And then there's some potential long-term effects. It's more likely than the other therapies we've mentioned to cause ejaculatory problems, permanent, irreversible ejaculatory problems. About a 10%, I think it's lower than that, but 10% quoted risk of erection issues. That's more common when we use the older types of electricity. Very low chances of incontinence or scar tissue developing in the urethra. So how does it work? Well, pretty much any of these laser therapies, the TURP procedure, even an aquablation has the same idea. You think of the prostate like an orange. We're coring out the flesh of the orange and leaving the rind behind. You can do it with an electrode here, the TURP procedure. You can do it with a laser. You can do it with a water jet. They all work the same way. So this is kind of my pathway for that. Someone's got a large prostate. We might try medical therapy first. If their prostate's is enlarged, but it's on the smaller end of enlarged and their symptoms are mild to moderate, that's where we're going to talk about that UroLift as a good option. If we've got severe symptoms or abnormal anatomy or if prostate's in the medium to large range, that TURP procedure, transurethral resection of the prostate procedure, is going to be a good option. Severe symptoms and a large, extra large prostate where it's getting above 120 gland. I would then talk to patients about aquablation. It's a procedure that my partner, Dr. Becker, does. A HOLEP is a laser procedure, not done in Evansville, but we can always refer you out. Or robotic prostatectomy. That's not the same thing we do for prostate cancer, but there's a way to do it where you're coring out the flesh of the orange sort of thing. And I can do that for folks as well. And that works very well when you have a very, very large gland. All right, so now on to the elephant in the room. That's why we're doing a webinar here, because we're going to talk about erectile dysfunction. And, you know, men can tend to be embarrassed about that, but like it or not, it's incredibly common. Okay, so we all know what it is. It's that inability to achieve or maintain. It disappears quickly. Erection sufficient enough for intercourse. How prevalent is it? It's incredibly common. I tell most men, if you live long enough, you're going to experience it at some point. 1 in 5 American men have said they experience it. Almost 40 million American men are affected by ED and seek treatment for that. So how do you get an erection? Well, obviously stimulation is the first part. So with stimulation, the nerves, from the brain send down signals to the penis. That causes the muscles around the arteries to relax so that blood can flow into the penis. It also causes the muscles around the veins to tighten so that they close so the blood can't get out. So for an erection to take place, you need intact nerves, arteries, and veins. That's all important for erections. So because of that, erectile dysfunction is usually going to be a symptom of a greater health problem, bigger health problem. So I'll tell most men, listen, you don't just have ED, you don't just have erectile dysfunction, you've got diabetes. And one of the symptoms of diabetes is erectile dysfunction, or you've got cardiovascular disease. One of the symptoms of cardiovascular disease is erectile dysfunction, because that holds true for the most part. So talking about diabetes first, well, incredibly common, obviously. 15 million men in the United States have diabetes, and we know ED is one of the most common symptoms of diabetes. You've got heart disease, you've got neuropathy, you've got eye problems, you've got erectile dysfunction. They all go with diabetes. It's often more severe than someone who doesn't have diabetes, and it's often less likely to respond to some of those medications. So why? Because diabetes affects nerves and blood vessels, just like you get the neuropathy in your hands or your feet, or you get cardiovascular disease. It affects those nerves and blood vessels. And because the medications are stimulating those blood vessels, they may be less likely to work. Heart disease, very common. We talked about that already. Erectile dysfunction, I'll tell men, it's kind of the canary in the coal mine. We know it's a risk factor. It's a predictor of cardiovascular disease. So you may say, no, I'm fine. I've never seen a cardiologist. I've never had a stress test. Well, we know that men with new problems with erections are more likely to have a problem with cardiovascular disease in the next 2 to 3 years. So people who develop new cardiovascular disease, coronary artery disease, almost 70% of those cases had erectile dysfunction before they developed coronary artery disease. And why is that the case? Because the arteries that go to the penis, the penile arteries, are smaller. And so if you start to develop obstruction, plaque in your arteries, the smaller arteries are going to be affected first. And so you'll get less blood flow to the penis. So important new problems with erectile dysfunction to continue working with your primary care doctor on your, like we mentioned, blood pressure, cholesterol, diabetes, smoking, all of that good stuff. So risk reduction, how can we treat and reduce your risk of developing or worsening your erectile function? Same things we talked about earlier: diet, regular exercise, quitting smoking, losing weight, reducing your stress. All the things that are good for your cardiovascular health are going to be good for your erectile health. Prostate cancer, we also talked about. If you're on the webinar or tuning in later and you have prostate cancer, I'm going to be doing a separate event about a month from now in September on prostate cancer survivorship. So I certainly encourage you to tune in for that, because we know that prostate cancer treatments have major sexual and urinary side effects. But whether or not you get radiation to your prostate or surgery to remove the prostate, those blood vessels and nerves going to the penis are going to be affected because they go right along the prostate, as you can see in the diagram now. So permanent, irreversible erectile dysfunction is a very common problem. Sometimes it's temporary, sometimes it resolves with time, but very, very common problem among prostate cancer patients. So what are the treatment options? We're going to go through these. Some of the things that are not good treatment options, though, first, at least I should say yet, these are all things that we consider to be investigational. There's not solid data that any of these things work. So I don't want anybody to be a guinea pig and be targeted online or anything like that. But the shockwave, particularly any of those handheld devices, shockwave treatments for ED not known to work. There are some trials underway for that, but they're going to be at major centers and as part of randomized controlled trials. Stem cell therapy or injecting your own plasma, not yet known to be effective, but all these things are being researched. What do we know can work? Medications. These are the PDE5 inhibitors, Viagra, Cialis. Those are the generic, or those are the brand names. We don't use the brand names anymore. We use generic for cost. How do they work? Well, they just increase blood flow to the penis. They have a variable success rate. So probably about 60% of men are going to see some success from one of these pills. You have to take them properly. You got to time them with when you want an erection. Still requires stimulation, not going to just happen automatically. And they have this potential for significant side effects: headache, facial flushing, sinus congestion, changes to your vision occasionally. Those would be more common side effects to these medications, but they're really common because they do work for some men. Most men will tell me they work okay, and for some of them, that's all the more they would want to do. But we use them very commonly, and I wouldn't let the finances of that stand in the way. Some insurance companies don't want to cover these, but we've got ways I encourage people to use GoodRx, if you're not familiar with that, to kind of shop around for the cheapest price and use that instead of running it through your insurance company. If you're buying a generic medication, they'll usually have that option on GoodRx. So injection therapy, that's something we use very commonly as well. That's where we're going to actually prescribe you an injectable medication. You're going to come to the office and we'll teach you how to do it, but you have to inject this medication directly into the penis. So it's kind of like a diabetes needle, but it goes in a different spot, and works almost right away, within the 30 minutes. So you got to inject it right before you want an erection, stored in the refrigerator in between. Again, kind of works variably. Probably 50 to 60% of men are going to see success with that, but because it's painful and not always allowing for spontaneous erections, most men are not going to continue it long term. But we do see some men to say, this is working great for me. It's my maintenance therapy. I have no problems. It serves all my needs. And so that could be a good option for people as well. Common side effects: pain, obviously. It is the treatment for ED that has the highest side effect of that erection that lasts longer than 4 hours. and that's not something you want to ever experience. That's going to land you in the ER with some awful treatments that none of us want to have to do to folks. So you always want to start with the lowest possible dose and titrate up very slowly if you're doing injection therapy. There's external vacuum devices. In my practice, I don't have a lot of men that have found that to be very successful, but something you can research online. Pretty low risk with that, but usually satisfaction rates are pretty low. You do have to use a ring at the base because it's pulling blood into the penis, and then a ring is going to keep the blood, in the penis, because that's one of the problems. The veins are letting the blood back out. And so because of that, it can cause some pain or discomfort, with erections. Suppositories, so you can put medication into the urethra instead of injecting. You can put medication in either a pill, suppository, or they make gels too. Again, I don't have a lot of men that do this long term. Some of these are more brand name and can be a little bit more expensive. But the biggest side effect I hear about is burning, some pretty intense burning from that medication irritating the urethra. It can cause low blood pressure. So the first couple of times you administer it, we do need to monitor you in the office to make sure you don't have any of those major side effects of passing out and then having severe dizziness. So most folks don't use that long term, but if you're looking to try all options, this would be one more. One of the things we're going to talk a little bit more about here is a penile implant, something that not many folks have thought about or heard about. And frankly, I think as urologists, we probably don't do a very good job of letting people know about this option because it sounds scary, it's a surgery, but the data would show that it's the most successful treatment for erectile dysfunction, success being satisfaction with the results and longevity. How long can you continue this therapy? Because most folks will see a continuing working implant for 10 or more years after it's placed. So there are several different types of implants, types and brand names for implants. Two major brand names for implants. But we're going to talk about the three-piece inflatable implant. That's the most common one, and it's the one that I would place most commonly. So just another little video here to show how that works. So it's got 3 components to it. They're placed through a small incision in your scrotum, maybe an inch in size. And this is going to show you kind of how that all works. So you've got the reservoir that's sitting up here in your pelvis. I don't know if you can see the mouse, but that's the reservoir that holds saline fluid. These are the cylinders that replace the natural erectile bodies in your penis. So instead of filling with blood, they fill with saline. And then this is a pump that sits down in the scrotum, kind of like a third testicle. And that is what you activate to move the fluid from the reservoir into the cylinders. And then when you want the erection to go away, you would push on that button, and that allows you to push the fluid from the cylinders back into the reservoir. So pretty cool technology for sure. So as I mentioned, it's a quick, 30 to 45 minute outpatient surgical procedure. Make a small 1 inch incision or so in the scrotum. Place that device in there. You wake up with a big wrap around everything, a catheter for a night, and a small drain. We'll see you back in the office that week. You usually can return to activity after 2 to 4 weeks, but we certainly want you really limiting activity for those first 2 weeks. And then it usually takes 4 to 6 weeks to heal. We usually are teaching people how to use the implant around 5 weeks to return to sexual activity. Well, does it work? Yes, it's proven. This is not something that's experimental. It's been around for decades. Probably 1 million men worldwide have had an implant placed. It's very common in the United States. I've personally, in my practice, placed well over 100 of these. So it's very common, probably more common than you'd think. And men obviously aren't running around telling everybody about it because you wouldn't know if anybody had this unless they specifically told you. But it's got good data for it, very high satisfaction rates. It's generally covered by your insurance. It's long lasting, 10 or 15-year life span of these devices. And it returns you to those natural, spontaneous erections that are reliable. So of course, it's a surgery. It's going to have higher risk than any of the other things we talked about. So it's a small incision. There's going to be risks of infection. It's a foreign object. We're putting it in your body, just like a hip or a knee replacement. It can get infected. Those risks are very, very low. And we take a ton of extra care to reduce that risk. It's going to be higher in people with diabetes or smoking or some other conditions. If it ever got infected, which would be very uncommon, but if it got infected, it would have to be removed. Bleeding, that risk is very low as well. That's why we leave a drain afterwards and we have you minimize your activity, but bleeding or blood accumulating in the scrotum would be a small risk of that. Pain, it's a sensitive area. Of course, it's going to have some pain associated with that. It's a mechanical device. There can be mechanical failure of any of those valves, tubes, components, but that risk is pretty low. But what I also tell folks for sure, what we want to understand is this is an erection surgery. It's to restore function. This is not a cosmetic surgery. It's absolutely not a lengthening procedure. I don't know of any procedures that we can do to increase your length. And most men are going to tell me that it looks shorter than it did when they were younger. And that's because having erectile dysfunction for so many years leads to the loss of elasticity, loss of stretch of those natural fibers in the penis. So we can't make it longer. You would generally pull on the penis with some gentle stretch, and that's as long as you would expect. And for most men, that's the functional result that they were looking for, and they're very, very happy with that. But an important part of the discussion process that we would have. Insurance coverage is pretty darn good. So most companies, Medicare, et cetera, are going to cover the penile implant surgery. If it's something that you're interested in, we'll go over this, but you set up an appointment and we're going to run your insurance and come up with some estimated costs that you would be responsible for. So you know, even before you have the consultation, kind of what costs would be expected. So to summarize with all that, erectile dysfunction, very, very common. It's usually associated with other life-threatening conditions like diabetes and cardiovascular disease. There are a lot of different treatment options that have varying degrees of efficacy. Certainly medications are usually a good place to start. And medications are a thing that you don't need to see a urologist for. You know, we're happy to see you, but you don't have to spend your time and energy seeing a consultant for that. You can definitely talk to your primary care doctor and they would very routinely prescribe those medications. But like I mentioned, use the GoodRx card if cost is an issue. Penile implants are a good permanent solution if you're kind of tired of dragging your feet with this and want to get back to those spontaneous, reliable, natural erections. I'm happy to talk with you more about that. Obviously, talk to your partner about all of this as well. That's an important part of the consultation. So we talked a lot about urology, men's health, common problems of prostate cancer, BPH, and erectile dysfunction. I mentioned you could talk to your PCP about any of those medications for BPH like Flomax or the Viagra, Cialis for erectile dysfunction, and they'd be happy to start you out on those and see if they work for you. If you want to talk to us about some of those more advanced therapies, we've got the number listed here for the urology department. You just call that and you'll be able to schedule an appointment with me. If your insurance company or you want your PCP to refer you, so it's a consultation instead of a self-referral, you can certainly talk to them and even ask them to send me a message and we'll be happy to work you in. If you're interested in a penile implant or any of the implant surgery, we'll send you a separate link where you can sign up for appointments there. We have those on a special days where we have the device reps and some, the implant is available and where we get all of the insurance pre-authorizations ahead of time. So we've got separate appointments for those specific consultations. So we've got some references here, which you'll see. We'll share these slides with you later. And as I mentioned, my website, moreurology.com, has a lot of really good resources. So now we'll take some questions. Let me see if I can figure out how we did that. Stop screen sharing. Okay, there we go. And so let's see here. Okay, it looks like it's recording my, okay, go. All righty, so I can see the chat now. If anybody has any questions, I would be happy to answer them. And these are anonymous, so folks would not be able to see who submitted them. We'll just give it a few more minutes to see if anybody has any questions. You can always schedule an appointment and ask them then. We'd be happy to get back with you. Let me check this real quick. All righty. Well, I'm not seeing any questions, so I certainly thank you all for tuning in here. I hope this was informative, and we will be sending you out an email with the slides, that link for the implant appointments, as well as that phone number. Again, if you want to schedule an appointment, we'd be happy to see you in the office. All right. Thanks again, everybody.